So welcome to our medical screening for foster and kinship care children webinar. We scheduled for an hour, but the good news on Friday afternoon, end of the week, Friday the 13th, is that this will not take the entire hour. However, if we need the entire hour to answer questions or address concerns, we are certainly happy to do that. So we'll start with introductions. As you all know, I'm Claire Miette, the Director of Nursing for OPH. We're excited about this collaboration with our partners, with the Department of Children and Family Services for this new initiative. I guess what I want to do is reassure our staff that this initiative, while it seems to be something new, it is something that we do every day. It is what we do. It is what our public health nurses do. And so just to reassure you that we're not going to be asking you to do anything out of your comfort zone or anything that you haven't done in the past. We're also privileged to have our partner on this webinar with us, and I do want to take the opportunity to introduce her and afford her the opportunity to give us some opening remarks and any words of wisdom that she would like. So on the webinar with us is Ms. Toni Buxton, who is the Foster Care and Transitioning Youth Daycare Services and Tribal Relations Manager of Child Welfare Programs for DCFS, Department of Children and Family Services. Toni, I'm going to unmute you. So give me just a second. Toni, are you there?
Can everyone?
Okay, I've
Yes.
unmuted you, Toni.
Can you hear me?
Yes.
Great. And thank you so much, Claire. This is a partnership that we've been working on for a while now, and we are very excited about the opportunity to partner with our folks over at OPH. We utilize the public health units in so many ways in providing care to the children that are in our responsibility, and so we know that we can count on a relationship where our children will get quality care through this partnership. The Department of Children and Family Services has had an accredited child welfare program since 2003, and periodically we have to go through reaccreditation to retain that accreditation. Currently, we're in that reaccreditation process, and the new standards for providing medical care to children in foster care requires that within 72 hours of a child entering the custody of the state, that we have to have an immediate medical screening to assess for infectious and communicable diseases so that we can immediately initiate treatment for these children to ensure they get the best health care possible while they're in state custody. And as you can all appreciate, it's very difficult to get a doctor's appointment, even with their current primary care physician, pediatrician, within 72 hours. And so to be able to fully serve all of the children in our custody statewide in rural as well as urban areas, we had to find a way to be able to do that with qualified medical practitioners. And of course, this area, infectious and communicable diseases, is a specialty area for the Office of Public Health. And so utilizing a partner agency with the expertise that your staff have to help us achieve this and retain our accreditation will also help us to ensure that our children are getting the best possible care that they can. So we're very excited that we're in a position to begin this partnership and begin serving our children.
Thank you so very much, Toni. Okay. So as Toni so eloquently said, the goal of this whole partnership, this collaboration, is to be able to provide for an initial medical screening as well as assess for any infectious and communicable diseases for any child that would be entering into the custody of the state through the state child welfare agency within a 72-hour period of custody. So we wanted to present to you all what this memorandum of agreement and contract is for, as far as for presenting the responsibilities of each agency. And so you have this. I wanted to preface all this by saying after the webinar, we will make available the copy of the PowerPoint presentation as well as it's being recorded. So we will send out the recording as well as soon as that is available. So as far as for responsibilities for the Department of Children and Family Services, which they have provided to us a listing of all of our contacts within DCFS in our at the regional level and parish level, their phone numbers, all the contact information, emails, fax numbers, and that will be disseminated after the training, so you all will have that. The DCFS contact person will be responsible for making contact with the appropriate. I'm sorry, Connie just stepped in and said you all are not seeing the screen. Okay. I was just alerted that you all could not see the screen, so I'm hoping that we're trying to get the screen up and we have to go back to the beginning. I'm sorry because, okay, can you test it? This is okay. Sorry, again, I have to apologize. This is new technology, so we're trying to get there. Okay, so the goal of our collaboration and initiative Okay, take 3. Okay, so the goal of this initiative, we're rewinding, and hopefully this webinar will cooperate with us for the remainder. The goal of the initiative is to be able to provide for initial medical screening, as well as assess for any infectious or communicable diseases, as you heard Tony talk about just a few minutes ago, for any child that enters the custody of the state through the State Child Welfare Agency within 72 hours of custody. And bear with me, I'm trying to advance the slide. So we'll present the responsibilities and what the actual contract language says in regards to what our partners, DCFS is responsible for, as well as followed by the responsibilities of OPH. And so for DCFS, which they've already provided, we do have a list of contact names, phone numbers, emails, fax, all the contact information, and we'll disseminate that after the completion of the training. So we'll send that out. The contact person from DCFS will also be responsible for making contact with the appropriate regional nurse manager and or his or her designee, which it may be a parish nurse supervisor. We're not going to specify from headquarters level how to best make this work for you in your region. However, we will provide to DCFS the regional nurse listing as well as the parish nurse supervisor listing. So they'll have a primary contact, which is that regional nurse manager, and a secondary contact, being that parish nurse supervisor. So they'll have two options, but we've asked them to contact the regional nurse first. If no response, then they will reach out to the nursing supervisor. The DCFS staff member will accompany that child to the health unit and will be able to provide all of the necessary registration information for the child that they are bringing in, and will remain with that child in the company of that child throughout the screening and assessment. They will also, of course, provide OPH with payment on a monthly basis for any services rendered for the previous month. So we will be billing out for these services with DCFS, and an analysis was done, and the agreed upon rate is that we will be invoicing DCFS $75 per child. And so that is what the contract language says and what we will be invoicing DCFS monthly for. That invoicing will occur roughly around the 17th of the month, and so we will be providing them with a listing for the previous month. I know one of the questions that will come up is, when will this be implemented? Once we complete this training, and as we go through it, you'll see that we will, for lack of a better term, be open for business beginning Monday. We were supposed to do this quite a long time ago, even before EHR was implemented, and the project has really been delayed due to varying factors, but we will be open for business per se beginning Monday. So as far as for the responsibilities of Office of Public Health, we have them listed here, and I'll run through them for you, is that the OPH will provide to DCFS just what I just spoke about, a regional nurse manager listing and a parish nurse supervisor listing, and contact information as well. The clerical staff will be responsible for inputting the information, just as they do with any other patient, for the medical record or into the EHR, as they already do. If they do not exist in our system, they will be entered as they are currently. If they do exist, then the child's information should be, of course, updated accordingly. The DCFS worker that brings the child in will also be able to assist with being able to provide any required information. The appointment type when putting these clients on the schedule is CHSC, which is our Old Child Health Screening. However, the new update and definition for this is for specifically for these children only. And then in registering the patient, we want to make sure this is a very, very critical factor. This is how our reports will be run. This is how our invoicing will be done. We need to make sure that from a clerical perspective and as well as a nursing perspective, to verify that the financial group is accurate, that these children's financial group should be selected as DCFS foster children medical screening. So I just want to reiterate that point again. We have to make sure that these children are selected in the financial group of DCFS foster children medical screening. Very important. How this differs from our other services is that the invoicing to DCFS will happen and the billing will happen an invoice system. So from our DHH fiscal to DCFS, and DCFS will interagency transfer that money's back over to OPH. So it's not the typical billing system with the EHR that we are used to. However, that information and the required reporting that is necessary to give back to DCFS is all very specific to this financial group. So I can't reinforce that enough, is to make sure that this financial group selection is accurate. So some continued responsibilities for OPH is that the public health registered nurse, the RN, will perform the screening or the assessment of the child just as you do any other client in the clinic, in the EHR, document the findings, make appropriate referrals as they are necessary, and provide treatment as needed. And we're talking about treatment as needed. You'll see in a subsequent slide that that is in the realm of things such as STD and TB. We will be seeing these children just as we would any other client according to our existing DHH OPH programmatic policies and procedures. Again, it's not anything different. We are going to follow other programmatic guidelines, and these children will be seen in the same manner. That nurse can assist and should assist in locating a provider or a medical facility to facilitate that child being seen for any urgent conditions upon their screening. And then DCFS will ensure that the child has a full medical exam within 7 days. So as part of their agreement, and I'm not sure if Tony hit on it, but from my understanding, and Tony, you can correct me if that is wrong, but from my understanding, is that they have to have this screening for infectious and communicable diseases within 72 hours. And then they have to have a full medical screen by a clinician within 7 days. So that initial assessment, if there's anything that we suspect or pick up or anything that's indicated that will require further treatment, then we just simply refer to emergency room or provider, and the DCFS worker will be there to help facilitate that as well. And again, the next bullet just talks about the billing, and I'm not going to rehash that again. The only thing I do want to say about that bullet is that the report that will be generated, the things that DCFS has asked us for is, of course, the name, date of birth, social security number, and date of screening on every child that is seen at our clinics. And prior to the webinar, I was sitting working with the epidemiologist trying to figure out the fields that we would specifically ask for. And we are still working on that report. We do have the minimum that DCFS has asked for. However, for our own intentions, we're looking at things such as CPT coding, as well as who provided the service, and so on and so forth. And as soon as that report is finalized, we will send a copy of that out to everyone in the field for your information. So what does the screening actually look like, or what does it entail? So I wanted to give you the minimum, the basics of what the expectation is that that child, when brought in, of course, will get an initial screen by a public health nurse. They will go into links and review immunization status. If they need immunizations, those immunizations will be provided. If they're behind, we will, according to our existing schedule and protocol, attempt to catch that child up and then refer them out to their medical provider. So if anything is needed from the immunization realm, that we will address that at that time. They will assess for things such as common cold, any viral symptoms, bacterial syndromes, or any parasitic syndromes. So anything that could potentially be infectious or communicable, we want to kind of assess for, and that's things that we do every day, as well as assess for any symptoms or anything in the realm of tuberculosis, so really anything communicable, as well as STDs dependent on the age of the child. And we know that if it is an instance where sexual abuse may exist, that we would refer immediately and nothing would be done in that realm. And so looking at our core public health functions, STD, TB, and immunizations will be the core responsibilities. So as far as for what's required, the initial screening, we want to make sure that the documentation of the screening and the assessment of the findings, so the encounter summary, and the recommendations for follow-up. So the documentation done by the nurse will be given to the DCFS representative that accompanies that child, and also to print out the immunization record out of links for that particular child as well and provide that to the DCFS worker. Now, DCFS assigns each child what's called a Transportation Information Payment System number, or TIPS number. And they have asked that this particular number, which the DCFS worker will have this number on this child, be included in the encounter summary. So we are going to insert the TIPS number into the chief complaint. So when you're in the EHR entering the chief complaint, you want to enter exactly as it appears here, DCFS child entering foster care and TIPS number, and then go ahead and insert that particular number. And Tony, I'm sorry, did you speak a while ago? I just noticed that you were on mute. I'm going to unmute you. And is there anything in particular about this TIPS number or anything you want to add at this point?
Yeah, I wanted to just add that I apologize. I must have misspoken when I was giving you the information earlier. It's called a tracking information payment system number. So instead of transportation, it's called tracking.
Okay.
And as a part of our accreditation, we're having to move that initial full medical exam up from 7 days to 5 days. So we will be trying within 5 days of the child entering foster care to get them in for that full medical exam. And then I just wanted to add a little bit of clarification about some information provided at the beginning, where it said that the liaison that we've identified for our parishes and regions would be the ones contacting OPH to set up the screening. We'd hope that the individual workers or foster parents assigned to that child would be able to make that call, and our liaison would be there to work out problems. And then it had stated in the slideshow that our workers would be the ones that were bringing the kids into the visits. We want it to be either our worker or our foster parent, whoever is able to do that, so that we can make sure that child gets there as quickly as possible within that first 72 hours. So I just wanted to make a little bit of a clarification around those two things, so no one would be confused, because I can see there are several of our staff on the call.
Okay, great, Tony, and thank you for that clarification. We will make those edits before we send it out or disseminate this out to the field, and appreciate that up-to-date feedback from you.
Thanks, Claire.
I'm waiting for the slide to advance, guys. Screen is slow. Okay, so for referrals that require immediate attention, of course, will occur as necessary. So that would be immediate. And as you heard Tony just say, that while they get the screening, the initial screening within 72 hours, that they will have that full medical exam within 5 days. As far as for treatment for any identified STDs, any of those needs, that will continue as we do on a daily basis. That will be provided according to our current STD standing orders that we follow now for any treatment of STDs, STIs, STDs, and of course documentation of whatever treatment will be provided. We wanted to address coding because we sort of thought that would come up for this initiative. As far as for CPT coding, that will all be the same procedures that you are doing in the EHR. For instance, the nurse visit will either be the T1001 or the 99211. As far as for diagnosis codes, this is what we have provided to you here, is that depending on the age of the child is what diagnosis code will be entered. And there will be a pick list in the EHR with these included. However, if something is done, and I'll use immunizations for an example, if the child needs an immunization, we would encourage you to go to the immunizations pick list and identify the administration code and the immunizations that are given as you currently do into the EHR, and that way it will all be documented as far as for what is done for the child. Remember that the billing is not done directly from the EHR as with other services. However, for reporting purposes, it is important that we accurately code. So for newborns up to 28 days old, the ICD-10 diagnosis codes for a newborn that is less than 8 days old will be Z00.110, and for a newborn that is 8 to 28 days old is Z00.111. If the child is over 28 days old and everything is normal, it is the first, the Z00.129. And if any abnormal findings, it is the second, the Z00.121. And so Tony had provided us with some data early on in the project as far as for what the expectation, because you're probably thinking, oh my gosh, how many children will be coming through the door? So wanted to show you the data from fiscal year 15 is what was shared, that for that full year, the total number of kids was right around 3,900 children. And then, so you probably figuring or thinking, or at least we were thinking, you'd be thinking, what does that mean for my region and how many are we talking about? So we broke it down for you so you can see here. Try to give you an average or an idea of what the potential might be. Tony, I was going to ask you, because our Region 8 folks are on here, to, if you could identify, there is one particular clinic that you've had an excellent relationship with, and they've agreed to see the children. So in Region 8, they may have a reprieve of some sort because you have a very good provider there. Could you speak a little bit to that?
Sure. In the Monroe area, the staff there were able to work out an agreement with a medical clinic there for their staff to be able to see our children and provide these screenings very quickly. And they were able to work that agreement out on their own, and that medical provider was very responsive to helping them to make sure that they were able to achieve the best health care possible as quickly as possible for their children in that area of the state. I don't know the exact name of the clinic in that state, but if we have any of our Monroe staff on, please type that into the chat box. We would love to be able to identify that provider who's been so cooperative in trying to help us with this.
Yeah, it would be great for our Region 8 folks to know as well. And if we don't get it during this webinar, Tony, if they could let us know that, we would certainly make sure our Region 8 folks get that information.
I'll be glad to follow up on that.
Thank you. I'm trying to advance the slide again. It's just a little delayed. Apologize. But what we wanted to do next is give the field an idea. The form has been sitting in the EHR, so if you were curious and took a look at it, that's great. But I'm going to stop talking for a little bit and ask Connie Bullany, our Assistant Director of Nursing, to review the form in the EHR as soon as I can get the slide to advance. I think every time we unmute somebody, it delays it or something. Okay.
Good afternoon, everybody. The form is pretty straightforward, and it consists of two different screens. The first time you go into medicine and go into your forms, you will need to go into CSHS, and there you'll find the communicable diseases screening form. And just as you've done with the other forms, I recommend you pen it, and then you won't have to go back into forms again that particular way. And so, as Claire mentioned in the chief complaint, you should be entering DCFS, child entering foster care, and that TIPS number, whatever that number happens to be. From there, it is a series of questions of things that are happening to the child now or in the past. So in the first column on your left, that happens to be what we're looking for today. Does the child have symptoms of a sore throat, a runny nose, a cough, cold sores, nausea, vomiting, diarrhea, rashes, vesicles, any problems in the hair like lice, scabies, or any lesions on the lip. And yes, we do want you to identify by checking either yes or no in those areas. As you know, when the summary comes out, those particular items will be identified, and those are needed. On the right-hand side, it asks, has the child been diagnosed with? And so you're going to really be depending on the guardian or the social worker, whoever is with the child, to help you address that. If they don't know it, I suggest that in that box where we can open and write in document, that you put that it was unknown. And then in the bottom box, has the child been exposed? It would be the same thing. But over the past 4 weeks, we're looking for chickenpox, mumps, measles, German measles, or tuberculosis. And then directly at the bottom, encounter information source would be whoever the child comes in with. If it's a foster parent or whether it's a social worker, you would enter that in that particular box. I need to move. Thank you. Okay, the second part of the screen is the area for immunizations. We're interested in whether or not the child is current on immunizations. So the first one says you've reviewed the immunization, but the child is not current. Immunization administration was given, whether it's yes or no, or whether or not it was, or if it was not given on that date, what was the reason? And once again, entering into the box your explanation will suffice for that. Then moving down to STD, in your children who are old enough to have experienced sex, you would want to ask them the questions. If it's a female, do you have a vaginal discharge? Or if it's a male, a urethral discharge? Or are you having pain when you're urinating? If they answer yes to any of those questions, either one of those questions, then of course we need you to go over to the reproductive health form to complete the assessment and the treatment. Right under that, any counseling or education that you give, you would check yes, you put yes, and then in the box, explain what you have counseled them on or educated on. And if the guardian knows the child's primary care provider, then you would enter that person's name there. And that ends the form part.
So we've gotten questions about what reporting category to use for the training, as well as when these children come in. So any time dedicated to this particular project or collaboration is charged to 0083. And again, we'll be sending this out to you. And here's a slide of just contact information, myself and Connie. as well as our DCFS partners, Tony and Charmaine Jarvis McGee, who's been named as our liaison at the state level as well. And so we just want to take this opportunity. If you have questions, the best thing we were advised to have you do is to type them into the chat box or the question box, as some of you all have been doing, and we'll take those questions. So Tony, I think the first question is, I think for you all, and just a contact maybe, but the question is, who approached the medical group in Region 8 to provide the services, OPH or DCFS? Well, I can answer that. That's DCFS. And is that an option for other regions? I'll start, and Tony, I'll let you finish. I think the options, if you can find an alternative option, then that's fine. The idea is to be able to get these children screened as timely as possible. So that is an option. Tony, I'll let you follow up with that. And I have to unmute you, so hang on. Okay, Tony, you're unmuted.
Hello, yes. If within your region you're able to get a Medicaid provider to go ahead and see the child so that we can utilize their Medicaid to get that screening completed, then that is definitely fine. And if that medical provider can go ahead and do the full medical exam as a part of doing the screening at 72 hours, that's fine too, so that we don't have to take the child back to an additional medical provider. This was just something that was not being found to be available or possible statewide in most areas. And so we had to develop a relationship elsewhere so that we could get the 72-hour screening and start making sure that we were able to serve any emergent needs our children might have immediately. And OPH was willing to partner with us on this. And as I mentioned before, they are the state experts on communicable and infectious diseases. So that's why we formed this partnership. But if through the child's Medicare, through the child's Medicaid and their Value Health Plan, you're able to go ahead and get that from another provider and go ahead and get the complete exam, go ahead and do that. That's fine.
Thank you, Tony. And I'm looking for questions here. And the question box for me is probably less than an inch, so bear with me. Here's another question. Since we have some consolidated clinics that do not have a nurse present every day, this will introduce an automatic display. Will this be a problem? I just want to remind, we have a 3-day, a 72-hour window, so we should be able to accommodate in that fashion. If it becomes a problem, then you all will need to let us know that. The next question is, if the foster parent brings the child in, will it become the nurse's responsibility to locate a doctor within 5 days? No. The nurse can certainly assist the DCFS worker. You all in public health, as we know our community resources. We know what resources are in our areas. If there's one that you know of that we can help to refer or to assist them to get someone in to get that medical screen by 5 days, that's what we'd like you to do. But no, it's not our responsibility. The next question, will the foster care workers or parents sign the same consent for services and release of information forms that we currently use in the clinics? Yes. Will they be completing the same intake forms that have to provide a photo ID? Our processes should not change for these children as it does for any other individual. I'm not sure that I'm answering that question. So if it needs clarification in the ask, please do so. What happens is if there is a weekend in between, we have 72 hours. Tony, what happens if we have a weekend and a Monday holiday? I guess the expectation would be that we see them on Tuesday or as soon as possible. Is that a fair assumption?
Can I be heard?
Yes. I
Oh,
left you
okay.
off mute, so be good.
Yes, I mean, we can only do the best we can do. We have to make every effort we can at the same 2 hours, and if it's not possible because of the scenario you described, that there's a weekend and either the Friday or the Monday is a holiday, then we just have to see the child as soon as we can, so that will be the next working day.
Thank you. The next question, will anything be sent out to the RAMs to instruct our clerical staff on the duties for this initiative, or should we just send out that one slide to the RAM on this presentation? Well, we would have hoped that the clerical staff were participating in this webinar, or the RAMs were participating in the webinar. But if this PowerPoint can be freely shared, again, it's not any change in processes. The things for the clerical staff is to make sure the correct financial group is selected, as well as appointment type. The next question, what if the medical screening shows a pruritic rash, which may possibly be scabies? Then does the nurse refer the child to the ER for a prescribed treatment? Either help or assist the DCF worker to get that child to a medical provider. If it is the ER, then if that's the only place where treatment can be ascertained, then the answer is yes. The next question is, will we need to do PPDs or T-spot and T-spots? You would not do anything differently than you're doing in clinic now. For TB, you would be assessing night sweats, coughing, any symptoms of tuberculosis. If you assess and pick up anything that may indicate that, then you would refer. Someone put, what is a RAM? I'm sorry, we do have some of our DCFS partners on the line. That is our regional administrative managers. Is the assessment the nurse will do only the items that are addressed in the EHR form? I'm sorry. It does not address listening to the heart, lungs, etc. Remember, these screens are for infectious or communicable disease. So what is in the EHR is what needs to be addressed. The next question, can nurses refer to urgent care centers instead of hospital ER? Absolutely. The ER would be our last resort. And that's the last question I see. Any other questions? Again, this webinar is being recorded. All of the questions will be sent. If you all so wish, we can certainly type up those questions and answers for you all and disseminate that as well. I'm happy to do that. Any other questions about anything else? I'm going to switch over and check the chat box right quick. Okay, I don't see any. I'm going to switch back to the question box. to make sure we haven't skipped any. If the nurse, we do have an additional question. If the nurse refers the child out for a problem, do we need to follow up on the referral? The DCFS worker will have that referral, and the child is in the custody of the state or the foster parent. So I'm assuming that they will follow up. It won't be our responsibility to follow this up. It's our responsibility to do the screening and help with the referral if necessary. Any other questions? And even with all the technical difficulties, we finished 8 minutes before the hour. Oh, another question, when does this start? I think I mentioned in the presentation, but it can be done beginning Monday. Dr. Davis and myself, we wanted to wait until you had the information, until the EHR was ready to go, before we would actually pull the trigger or flip the switch to say we could do this. Remember, the numbers are not that high, so we're not expecting an influx through the doors. However, it'll be a nice resource for DCFS to be able to have a place to get this screening for infectious disease and communicable disease, which is what we do in public health, done on a timely basis. Any other questions? I'm not seeing any other questions. So with that, I am going to stop the recording